Hello, welcome to sonography-radiology training channel. This series of videos is about basic radiology learning of chest imaging. This is the first video in this video series with title of A Technically Adequate Chest Radiograph Part 1. The outline of this presentation include introduction. After introduction, the technical factors for evaluating a chest X-ray is penetration, inspiration, rotation, magnification, angulation, and final teaching points. We can see these items in video part 1 and these another ones in video part 2. At first, introduction. Evaluating 5 technical factors will help you to determine if a chest radiograph is adequate for interpretation or whether certain artifacts may have been introduced which can lead you astray. These technical factors include penetration, inspiration, rotation, magnification, and angulation. At first, penetration. To determine if a frontal chest radiograph or PA chest X-ray is adequately penetrated, you should be able to see the thoracic spine through the heart shadow. What is the pitfalls of under-penetration or inadequate penetration? You can tell if a frontal chest radiograph is under-penetrated or too light if you cannot see the thoracic spine through the heart. Under-penetration can introduce at least 2 errors into your interpretation. First, the left hemidiaphragm may not be visible on frontal image, as you can see compared with a well-penetrated chest X-ray, because the left lung base may appear opaque. This technical artifact could either mimic or hide true disease in the left lower lung field, for example, left lower lobe pneumonia or left pleural effusion. To avoid such a problem, look at the lateral chest radiograph to confirm the presence of disease at the left base. As we can see here, consolidation in the left lower lobe pneumonia and evidence of pleural effusion in lateral chest radiograph. The second pitfall, the pulmonary markings, which are mostly the blood vessels in the lung, may appear more prominent than they really are. You can mistakenly think the patient is in congestive heart failure or has pulmonary fibrosis. To recognize pitfall, look for other radiologic signs of congestive heart failure, as will be discussed in the future videos. What is the pitfall of over-penetration? If the study is over-penetrated or too dark, the lung markings may seem decreased or absent. You could mistakenly think the patient has emphysema or pneumothorax. Or if the degree of overpenetration is marked, it could render a pulmonary nodule almost invisible. To prevent this complication, look for other radiologic signs of emphysema or pneumothorax. In emphysema, the lungs are frequently hyperinflated and the diaphragm flattened. To diagnose a pneumothorax, you should see a pleural white line. If you have any problem, ask the radiologist if the film should be repeated or not. Inspiration. A full inspiration ensures a reproducible radiograph image for comparison from one study to the next and eliminates artifacts that may be confused for or obscure disease. The degree of inspiration can be assessed by counting the number of posterior ribs visible above the diaphragm on the frontal chest radiograph. As we can see here, the posterior ribs, first, second, third, and the another ones. But before counting the posterior ribs, we must be able to differentiate between anterior and posterior ribs. posterior ribs are immediately more apparent to the eye on frontal chest radiographs. The posterior ribs are oriented more or less horizontally. Also, each pair of posterior ribs attached to a thoracic vertebral body. Anterior ribs are visible but are more difficult to see on the frontal chest radiograph. Anterior ribs are oriented downward toward the feet. Anterior ribs attached to the sternum or each other with cartilage, which is usually not visible on radiographs until later in life when cartilage may calcify. What is the important points of inspiration? If 10 posterior ribs are visible, it's an excellent inspiration. As you can counting the posterior ribs here, this is the first one, second, third, and the another ones up to 10. In many hospitalized patients, visualization of 8 to 9 posterior ribs is a degree of inspiration usually adequate for accurate interpretation of the image. What is the pitfall of poor inspiration? A poor inspiratory effort will compress and crowd the lung markings, especially at the bases of the lungs near the diaphragm. As you can see in this frontal radiograph, only 8 posterior ribs are visible. A poor inspiration may crowd and therefore accentuate the lung markings at the bases and make the heart seem larger than it actually is. The crowded lung markings may mimic the appearance of aspiration or pneumonia, so a lateral chest radiograph should help in eliminating the possibility or confirming the presence of basilar aerospace disease, which is suggested in the frontal radiograph. Now, rotation. The easiest way to assess whether the patient is rotated toward their left or right is by studying the relationship between the clavicles and the thoracic spine. As you can see in this schematic view, the patient is not rotated and medial ends of the right and left clavicles, which are projected on the radiograph, equidistant from the spinous process. This close-up view of the head of the clavicles demonstrates that each medial ends of the clavicles is equidistant from the spinous process. In this schematic view, the patient is rotated toward his own right. Notice how the medial end of the left clavicle is projected closer to the spinous process than is the medial end of the right clavicle. This close-up view of head of the clavicles in a patient rotated toward his own right shows that the spinous process projects much closer to the left clavicular end than to the right clavicular end. In this image, the patient is rotated toward his own left, so the medial end of the right clavicle is projected closer to the spinous process than is the medial end of the left clavicle. Another one, this close-up view of the head of the clavicles in a patient rotated toward his own left shows that the spinous process is much closer to the right clavicular head than it is to the left side. These relationships hold true regardless of whether the patient was facing the X-ray tube or facing the cassette at the time of exposure. What is the diagnostic pitfalls of excessive rotation? Significant rotation means the patient turns the body to one side or the other, may alter the expected contours of the heart and great vessels, the hyla, and the hemidiaphragms. This is a frontal chest radiograph of a patient markedly rotated toward his own right because the left clavicular head is much closer to the spinous process. Rotation can distort the appearance of normal contours of the heart and pulmonary hyla. Notice how the left hemidiaphragm being farther from the cassette than the right hemidiaphragm and appears higher than it normally would. The hilum could also appear larger than its actual size because of rotation. The heart and trachea appear displaced into the right hemithorax because of the rotation. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.